So how about you Nadine? How is the availability of Olaparib now changing your practice for the triple negative and the ER positive patients?
Yeah, I think that I agree with Tiffany completely. I think for triple negative, I mean, it would be, if I were going to reach for a single chemotherapy agent, I would reach for Olaparib. I think if I needed a doublet and somebody was very sick, that's a different story in the triple negative. I think we don't have a direct comparison to platinum, and I think if you do what you're not supposed to and look at a cross-study comparison of the TNT trial and the Olympiad trial, boy, the progression-free survival looks pretty the same, response rate in the first-line setting looks pretty the same, but I think the toxicity would be so much less. So to me at this point, single agent, triple negative, I would reach for Olaparib, as Tiffany said. The ER positive is interesting because in the Olympiad trial, those were endocrine-resistant patients. They had pretty much all seen endocrine therapy in the metastatic setting. So they're more like patients in Paloma 3 or Monarch 2. Almost none of them had seen a CDK4/6 inhibitor. So I agree. I guess if you're a purist, you would keep with your endocrine therapy as long as you felt that the patient was appropriate for that, you were getting response to endocrine therapy, and then when you're going to move to chemo, use Olaparib. Although I must say, I think to myself, I think of the toxicity with these two oral agents, and I think one could make an argument, if I had an ER-positive patient with a germline BRCA mutation who'd progressed on an AI, would I use a PARP inhibitor, would I use a CDK4/6 inhibitor? There's no direct comparison or data to really draw upon for that.
But that's interesting. So you both would really favor, in the triple negative, somebody who wasn't very, very ill, going right to Olaparib, for the first line treatment for that patient. I would too. I haven't had the opportunity to do it yet, but it hasn't come up yet. But I would do the same. I would do the same thing.
And can I have one more comment?
Oh, yeah.
In the Olympiad trial, and again, it wasn't platinum, but compared to eribulin, compared to capecitabine, the time to response was the same. It was about 45, 47 days. And that's important because we think, a pill, we think endocrine therapy, this is going to take a long time to respond. It was the same. So we need to get over that psychological barrier that it's going to take longer or something.
Yeah. Reminds, is a little analogous to the CDK4/6 inhibitor issue in the first line metastatic, but not for the germline BRCA, for the wild type. So it's very effective therapy, but if you have somebody that you heretofore would have given chemotherapy, are we comfortable using a pill instead? And again, the time to response is very, very quick, but it takes a little time to evolve those patterns, doesn't it? You know what I mean? So I think we're going to be probably getting there more and more. So that's really very interesting, and the hope is that the median PFS, when we move it up, will be, much longer. Yes. That's the hope, that we can see. And then in the ER positive patient where there's so many other options, and we do that first line CDK4/6 with 24 months median PFS. That's pretty much a stand up and salute.
But again, those are endocrine sensitive.
Those are endocrine sensitive patients. And it's really a mixture where the luminal A's outnumber the luminal B's, probably disproportionately, but the BRCA2s, would maybe be considered perhaps a little bit more aggressive, because most of the BRCA2s with ER positive, would probably fair to say, are more like a luminal B biology.
Interesting. I think the ER positives in all the BRCA carriers tend to be the luminal Bs more so. They higher oncotype recurrence score, higher proliferative rate, so they tend to be luminal B. They do.
Yeah. And all we've seen in the CDK4/6 studies has been the forest plots where everybody benefits a great deal more. But I don't know that I could quote you, from looking at, PAM50, luminal Bs, what the PFS versus the luminal A's. Probably a lot of that is still ongoing, a lot of that. But
just thinking about where to sequence this, say we leave first line off to the side, and that's where a CDK4/6 inhibitor is. We've all had women with ER-positive disease struggle with the bone-related adverse events from aromatase inhibitors, or some of the mucositis from, say, mTOR inhibitors. When you look at the toxicity profiles, actually Olaparib in that setting would be pretty well tolerated and very reasonable, I would think, to use for someone, even with ER-positive disease in the second-line setting, who's having a hard time with endocrine therapy.
And we all gauge it, right? How many lines of endocrine therapy we give depends on what's going on with the patient. How well did they do with the previous endocrine therapy? So everybody's going to be different in terms of how many lines of endocrine therapy. But it sounds like we're all on the same page that before we would go on to our next, like, oral capecitabine, for example, where that might have been what we would do next, we'd go on to Olaparib. Yeah, so that's really interesting. We're really moving it up. So that's really going to be interesting to see how that goes for the patient. We really hope we get those wonderful durable responses. We're just taking a pill. So